Hi everyone, my name is Ifrah Fatima. I'm a PGY1 in internal medicine at UMKC. I'm presenting our quality improvement project titled The Use of Multimodal Pain Management Regimen to Reduce Inpatient Opioid Use. The background of this project is rooted in the common use of opioids and the associated serious harm in hospitalized patients. The CDC has declared the opioid pandemic a national health emergency with 28,000 annual deaths from opioid overuse. A cohort study among non-surgical admissions showed that more than half the patients started on inpatient opioids received opioids until the day of discharge, which resulted in very poor pain control outside of the hospital and contributed to patients' opioid dependence. So for this quality improvement project, an inpatient pain management order set was developed. Opioid use was measured in milligram morphine equivalents, that is MMEs, among internal medicine inpatients admitted between December 2020 and February 2021, and post-intervention admissions between December 2021 to February 2022. Patients admitted for palliative care and patients receiving IV continuous infusion opioids were excluded. Results. Opioids were prescribed for 478 patients, of which 57% were male, prior to the order set implementation. The mean standard deviation number of inpatient encounters in the pre-intervention period was 3.9, with a mean length of stay of 7.7 days. During the pre-intervention period, 688.23 MMEs were used. The inpatient average opioid consumption was 89.38 milligrams per day of hospital stay. The highest opioid use was in patients with sickle cell disease, and it was 2,450.73 milligrams. The post-intervention data is still pending. Here is also a figure of the average opioid use by diagnosis, of which patients with chronic pain such as sickle cell disease and cancer patients were not a part of our intervention. The second figure is the baseline and projected decline in mean MMEs per encounter pre and post-intervention. Discussion. Considering these alarming trends, there's a concerted effort across medical specialties to reduce iatrogenic harm from exposure to opioids. Clinicians are being encouraged to use a multimodal approach to pain management. Our study has many limitations, one of them being that the study intervention was dependent on many stakeholders, and further, we were unable to implement our intervention in the given time frame because of a delay in implementing the order set. The conclusion being that pre-intervention morphine milligram equivalence appears to be high. By implementing a multimodal pain order set, we expect to see a reduction in inpatient opioid use post the intervention. Thank you.